move the eyeball downward and outward, but it spin also inside. When eyeball spin inside, it means it produces intorsion. It produces intorsion. So if someone asks, what are the normal function of the superior oblique muscle, this muscle, the normal function of this muscle are, yes, it depresses eyeball, it push the eyeball down and out, and entort. Entort, there are three functions. Again I will say, it pull the eyeball where? Down and out and in tort. Right? What does it mean? That again, that if this is your eye, right eye, right? I'm making it really too big. Right? This is 12 o'clock position. Right? Now what really happens? When this superior oblique is working, number one, it will move, eyeball will move downward. Secondly, it will move outward. Thirdly, it will spin in this direction. Right? So eyeball will be in this position. It will be looking down and out and like this. It is no more vertical. Right? This is intorsion. Am I clear to everyone?
That's right.
There is no problem. Anyone who is not clear, raise the hand. Okay. After having said all of this, now if superior oblique is paralyzed, what will happen? Let's suppose this is the muscle, this is the eyeball on the right side. If right superior oblique is not working, let's suppose trochlear nerve is damaged. One of the common cause of trochlear nerve damage is, number one, it can be congenital, rarely, but sometimes head injury. Head injury, because it has a very long pathway, head injury may produce traction on the nerve, or stretch the nerve pathologically, which may produce dysfunction in the nerve transiently. Or sometimes nerve is evulsed, it is pulled out from its attachment. Of course, then it will not recover. Right? So head trauma can damage the fourth cranial nerve. Then fourth cranial nerve can also be damaged by pathologies in cavernous sinus, like there is internal carotid artery aneurysm, or there may be a cavernous sinus thrombosis, right? Or in the orbit there may be tumors or direct trauma. But anyway, if fourth cranial nerve is damaged, what will happen? Which muscle will not work? Superior oblique. And if superior oblique does not work, it means where will be the problem? Problem will be there will be weakness of depression. It can, this eye cannot depress very well. Number one, weakness of abduction and failure of intorsion. Now imagine that these are my two beautiful eyes, right? And right eye, fourth cranial nerve is damaged. What will happen? Number one, apparently it may not look in a big trouble, but if I try to look down, normal eye will go down, it will not go down, especially in adducted position, because a depressor of the eyeball is superior oblique and inferior rectus. But if you adduct the eye nasally, I have turned like this, nasally, now the major depressor is superior oblique. In adducted position, right, affected eye cannot be depressed, unaffected will be depressed, there will be failure of depression. So problem is that there is some slight weakness in lateral rotation, right? This eye, right eye cannot rotate well on the lateral side. Why? But still lateral rectus is very strong. Is that right? But the real problem is in adducted position, it cannot depress downward. But very important thing is that major entorting muscle has failed. Which muscle has failed? Entorting. So if right eyeball has failed its superior oblique, it cannot entort, right? And it will go in this direction. Why? Because in normal eye, how it keeps its position, that superior oblique is entorting normally and inferior oblique is extorting. But when superior oblique is damaged, entorsion mechanism fails, but inferior oblique is working, which is supplied by oculomotor nerve. So what really happens? Extorsion occurs. So what is wrong with the eye with the fourth cranial nerve damage? Look at it. Right eye, left eye, and it is extorted. It failed to go depress properly, it cannot depress properly, and it is slightly and it is extorted. Problem with the extortion is that now the binocular vision is not well, because if you see an object, normally both eyes have alignment of their axis. If both eyes have full alignment of their axis, right, then the visual field which is observed by each eye, they overlap with each other completely, and we see one object as one object. But when one eye has distorted, you can say it is out of alignment, then the object which both eyes see, the visual field, the right eye will be slightly different than from the visual field from the left eye, and the object may look as double, and this situation is called diplopia. Right? Now this person will have two types of diplopia problem: double visual field misalignment of the healthy eye and affected eye, unaffected eye and affected eye. Number one, especially if you ask this person to look down, now normal eyeball will turn down and affected will not turn down. So this will have different visual field and this will have different visual field. So object will look double and vertically. One visual field will be looking downward, other is looking relatively upward. So you will have vertical diplopia. With that, when there is extortion due to failure of intorsion of the affected muscle, then that actually visual field from the right affected side not only is vertically making diplopia, the objects are also looking tilted. They will look like a tilt, angled as compared to the normal eye. Am I clear? Now, what is the solution to that? I will go to solution later. Before that, I want to show you some normal mechanism of intorsion, extorsion. Look, I'm looking straight. Now my both eyes are 12 o'clock position or 12 o'clock position. Red lines should be vertical. Is that right? Now, if I turn my head like this, eyeballs should become like that. But if eyeball become like that, both eyeballs are not parallel. Now actually, as soon as I make my head like this, both eyes turn like that. When I say both eyes turn like that, it means right eye undergoes extorsion and left eye undergoes intorsion. Am I clear? I will repeat it. Normally I am looking like that, right? If I make my head like this, then both eyes will rotate to keep the axis parallel, right? This is normal. This is normal. And if my eyes are like that and I tilt my head like this will turn like that. Is it clear? Now first I will show you in a diagram these mechanisms. Let's suppose this is my beautiful face with my eyes, and I'm a happy man because both eyes are in normal alignment, right? There's no need to make here. Okay, this is 12 o'clock position, right? Both are parallel, right? Now, if I turn I'm talking about healthy. Up to now there's no disease. Now, if I turn my head like that, what will happen? If I turn my head like that, right? Of course, eye positions will change, right? Now, what will happen? That still, I will still remain happy. You know why? Because it will rotate in this direction and that will rotate in that direction. So still it will be vertical and it will be vertical. It means by tilting head this side, this eye extort and this eye intort. Is that right? Let's suppose I turn my head on the other side. I turn my head on this side. I will be still happy if my nerves are working well. What will happen? That eyeballs will again spin. Right? Now this time, to keep the again 12 o'clock position as 12 o'clock, this will turn on extortion, and this will turn on intorsion. Am I clear? Okay, I will make it little different color of extortion and intorsion. Here it will be extorted if I tilt it on this side, and this will be intorted. And here if I turn on other side, tilt, what is this? Right eye will extort and left eye will intort. Am I clear? No problem. Again look, I turn like this, my right eye will, yes, extort, and right eye will intort. And if I do like this, then right eye will intort and left will extort, but they will keep their axis, visual field axis parallel. Am I clear? Now we come to the disease. Let's suppose this is a person who has a, this is not me, this is a patient now. In this patient, look at it, very sad. You know why it is sad? Because trochlear nerve on the right side is damaged. And if trochlear nerve on the right side is damaged, now as I told you, normally superior oblique intort and inferior oblique extort. If superior oblique is paralyzed here, can it intort?
No.
No. So failure of intorsion will make this eye what? Extorted, and now this person has a trouble. Number one, that all the objects in two visual field, the objects which are seen by the right eye visual field, they will be tilted. They will have a tilt. Number two, of course, when this person tries to look down, diplopia, vertical diplopia occur. Is that right? Now, question is that this eye is abnormally extorted. One way to correct this situation is that if you want to make, because here the muscle is paralyzed, you cannot intort it, but you can intort this to make this parallel with the affected eye. Now how to intort it? Turn the head opposite side. What you do? Turn the head to opposite side. So these patients normally keep their head tilted on the opposite side. Right side eye was affected, they will normally keep their head. These patients look like this, right? And also, number one, head is tilted to the opposite side and chin is tucked in. I will explain why. First of all, normally these patients learn to fuse the both visual fields and approach the binocular visual alignment. What they do, they tilt the head to the opposite side. When they tilt the opposite side, the affected eye, which is extorted, unaffected intorts, and both of them come into what? Into same alignment. That this was what? Extorted due to failure of the muscle. But unaffected eye, right, because its muscles are working well, right, when it tilts on the opposite side, it will intort, and when it will intort, then yes, both will become parallel. And in this way, these patients, to see the object, to fuse the both visual field from right eye and the left eye, right, they keep their head turned on the opposite side. So it's very natural. If right muscle is damaged, or right trochlear nerve is damaged, head will be tilted left shoulder to the, and if left is damaged, head will be tilted to right shoulder. Am I clear to everyone?
Yes, sir.
You have a question? You are just doing like this? If right trochlear nerve is damaged, head will be tilted to the left side. No, I'm talking about trochlear nerve, not trochlear nerve nucleus. Do you understand? Trochlear nerve, right trochlear nerve supply right muscle, left trochlear nerve supply left muscle. But when you go back, right trochlear nerve is connected with the left-sided nucleus and left trochlear nerve is connected with the right-sided nucleus. Am I clear? Yes. Okay, that's good. So now you will tell me, if person has damage, let's suppose, now I bring another patient. This is another patient. Here the damage is to the, this is also very sad, because damage is to the left trochlear nerve. So here the visual axes are it is tilted like that. Where the head should be tilted? Now look, this is extorted, we need to intort it. So where the head should be tilted? Yes, again, here. And in this case, that will become relatively vertical, am I right? Yes. And this I will intort and this will become okay. And now this is happy and this is also happy. Am I clear? Another thing that usually they say that when trochlear nerve is paralyzed, trochlear nerve is damaged, then of course not only head is tilted to the opposite side, chin is tucked in. Now why the person is trying to keep the chin in? Actually they want to keep the visual axis of both eyes above the horizontal, because the affected eye cannot look down. You get it? Because so if these patients move head like this, then both eyes should look down, but affected eye cannot look down. Affected eye cannot look down. So they keep head like this, like this. When they move it like this, they are keeping it up, right? So right eye will keep its movement rotation little up, and it is not forced to look down, because downward is somewhat failure, and left is healthy, so it will also keep it little up, and vertical diplopia will be eliminated. So these people not only turn the head on the opposite side, they also tuck the chin in. So it is like this. Okay? So this was all about, okay, I will just the last but not the least. Now you will tell me, this is normal. Now you will tell me which nerve is damaged, which trochlear nerve is damaged. Right. And now which trochlear nerve is damaged? Left. Okay. Now if right is damaged, where should be the tilt? And this will intort. You get it? Now if left is what? Damaged. And now it is, so where the tilt should be? Right. When right tilt will come it, and this will intort. Am I clear? Any question? Okay, let's have a break and then we'll talk about sixth cranial nerve. You have a question, okay. What is your question?
Can this damage is misdiagnosed with torticollis?
Oh yes, of course. He is talking about another condition that is called torticollis. Torticollis is a condition when on one side of the neck the muscles undergo pathological spasticity, and it will be like this. So some people have their this kind of position. So sometimes it can be confused with torticollis. Torticollis is a condition in which muscles on the one side of the neck may be under pathologically for prolonged spasticity, and these people are always like this. Is that right? And even I tell you something, sometimes fourth cranial nerve palsy is congenital, and in these babies, right, in early time it is not diagnosed well, because in early time eye mechanisms are very, you can say, efficient, but as we grow up then they develop the problem, diplopia problem, right? But if adult come and like this, if you ask him to bring his old photo, in childhood photo also they have a little tilt in their photos. Okay, so this was all about what? Yes, you have a question. We'll talk that in embryology, right? Any more question?
Sir, the intracranial nerve damage, why the depression is more affected during the adduction?
Okay, it's a very wise question. He is saying, in every book writes that in trochlear nerve damage, depression of the eyeball fails more when eyeball is in adducted position. Why? Very good. Okay, let me explain. This is your eyeball. Oh, sorry. It should be like this. This is your eyeball, right? Now, first of all, understand what is the normal mechanism of depression of eyeball. Normal mechanism of depression is, number one, inferior rectus. Inferior rectus is really not coming straight. It is coming from medial, it is approaching from medial side, and inferior rectus move forward and interiorly, right? And it pulls it downward. And above, the depressor is superior oblique. Now, let's suppose if eyeball is in abducted position, if it is in abducted position, inferior rectus still can pull it very well down. But if inferior rectus is like my finger, this relationship with the eyeball, right? It is not straight. It is not straight. it is angled. Now, if we make the eyeball adducted, can it depress it? So only depressor left is superior oblique. So that is why that if you really want to check the function of the superior oblique, what we really you see this failure of depression of eyeball, especially when it is in adducted position, because other depressor, inferior oblique, power is reduced. So real depressor becomes superior oblique, and if it is not working, then of course failure of what is this? Depression will be more evident. Am I clear? Any more questions? Okay, let's have a break, small break.